Financing and Reimbursement Methods by Professor Tammy.
Financing and Reimbursement Methods, Part 1. Introduction. Financing is any mechanism that gives people the ability to pay for healthcare services. So, if you want healthcare services, you have to get the money from somewhere. So, we're going to talk about that in this chapter. In most cases, financing is necessary to have access to healthcare. So you need money to pay for healthcare one way or another in most incidences. Sources of financing healthcare. 1. Private health insurance. 2. Public insurance programs such as Medicare and Medicaid. 3. Uncompensated or charity care. Complexity of financing. So how can healthcare be so complex? How do we end up paying? Well, there are many payers, many different types of plans, many different types of programs, and many different payment mechanisms. Economic perspective of financing. Working Americans finance their own health care and subsidize it for those who cannot afford it. Employer-paid insurance is in exchange for salary. Medicare tax is a type of prepayment plan for certain services received at age 65. Effects of financing in insurance. See Exhibit 6.1, Healthcare Financing and its Effects. If you have the textbook, it will be on page 129. 1. Financing of private and public health insurance enables access to healthcare. 2. Payment to providers. 3. Moral hazard. 4. Provide induced demand. That is, providers deliver covered services more liberally. 5. Technology and services with liberal reimbursement proliferated. 6. Total healthcare expenditures are greater than if the same services were to be paid by the patients. Effects of financing in insurance. See Figure 6.1, Relationships among Healthcare Financing. Insurance, access, payment, and expenditures. It will be on page 128 of your paperback. So when you look and you think about it, private employers and the government are the primary financiers of the healthcare in the United States. But for those who have their own healthcare insurance, it's usually paid by them. But a lot of times, there are a lot of things in the United States that we waste a lot of money on healthcare. So the end results are moral hazards and provider-induced demand waste healthcare resources and add to the rising cost of healthcare. Like, remember, we tend to write more notes, see the doctor more follow-up, use more technology. National health insurance enables supply-side rationing. This has not been possible in the United States. It's more possible and more like in Europe and Canada. The Affordable Care Act, ACA, also known as Obamacare, still leaves many Americans uninsured, whether it's indirect or demand side rationing, whether they want to be in it or not. Insurance is nature and purpose. Insurance is a mechanism to protect against risk. Whether it's your house insurance, it has fire insurance, hurricane insurance, etc. And also health insurance or your life insurance. Those are the different health insurance, and is used to protect in case something happens. Risk. The possibility of substantial financial loss for some event, like a fire or a car insurance. If you have car insurance, the insurance will help get your car fixed. But it depends if you have comprehensive or liability. Insured, which is the employee or beneficiary, an individual protected by insurance. Insurer, an insurance agency that assumes the risk, like GHI, Blue Cross Blue Shield, Oxford, Cigna, etc. Underwriting evaluates, selects, rejects, classifies, and rates risk. Premium, amount charged by insurers to provide coverage, cost sharing by employers and employee. Insurance is nature and purpose. There are 4 principles of insurance. 1. Risk is unpredictable for individuals. Really? Do you really know what's going to happen tomorrow or a week from now? Think about it. In January 2020, did we know what was going to happen in March 30th? 2. Risk can be predicted with some accuracy for a large group. So what happens is it's statistically that they look at history, like what groups have certain health histories and health outcomes, and they have a little prediction on how much risk this group may be based on age, sex, ethnicity, where they grew up or where they live. Insurance can shift risk from the individual to the group by pooling resources. So what this means is you may have a group that have people in various ages from their early 20s to maybe in their 60s. And those who are like older adults would need to go to the doctor more often or maybe have more medications versus those in their 20s and 30s are like healthy. So when you have a pool of people with various ages and also sex, then you're like, okay, one outweighs the other, so it kind of evens up. Losses are shared by all members. So think of it as something more communal, but it's not really communal, but it's based on groups. And a lot of times when you look at your health insurance, you see group number. And it's just, giving the health insurance an idea of where you fall in this group and how big is your group or how small is your group, what is your risk factor. Cost sharing. Insurance requires some type of cost sharing. The insured assumes at least part of the risk. So they have to pay like maybe a copay or a percentage of the medical bill. So it depends what their health insurance plan is. The purpose of cost sharing is to reduce misuse of insurance benefits. So when you think about it, if you get everything free, you're like, I'm going to the doctor all the time when I'm sick. Versus if you had to pay some kind of copay, they're like, let me think twice. Do I really need to go to the doctor? Three main types of cost sharing in private health insurance. 1. Premium cost sharing. 2. Deductibles. And 3. Co-payments. Deductible. It is the amount the insured, that means the person with the health insurance, pays first before benefits are paid by the plan. So, if you have, a deductible of $5,000, you must pay $5,000 first for your health care before your health insurance says, okay, we can start paying for it now. That's very similar to some people's pharmaceutical plans. Oh, you reach your deductible. You don't have to pay, or you pay a lot less now. Your health insurance is going to start paying for the rest of the medication. So this is based on the calendar kind of basis from January 1st through December 31st. It doesn't start in the middle of the year unless you start a new job or a new health insurance. So it's from January 1st to December 31st. Co-payment is the money paid out of pocket each time health services are received. So after you get your service from the doctor or the health provider, you will have to pay a co-fee. It's like the co-payment, like $15, $20, or maybe a specialist is $50, $100, depending on the fee based on your health insurance. Co-insurance is the percentage paid by enrollee for health care provided. So let's just say you had to pay 20% while your health insurance has to pay 80%. So if your bill was $100, you have to pay $20 and your health insurance pays $80. Stop loss limits total out-of-pocket costs. So once you hit a certain amount, you stop paying, or else you're going to be super duper like, whoa, this is way too much.
See you soon. And remember to read the book.